Seattle here. As you can probably see in the news, it's been a rough couple of months and a rough couple of weeks especially. But we remain under pretty strict measures, although Washington State's been one of the more successful responses. It helps by having some of the lead institutions in the states that address disease outbreaks. Having them based here has kind of helped. But as you can see on the news, the response in the states more broadly is kind of patchy. And we probably want to look to some of the countries I'm going to talk about now in Africa and some of the European countries where we're seeing some of the better responses. And a lot of that is based on their experience in having diseases before. And so that's where we can learn. We've had diseases in Australia, we've had disease responses, but nothing of this scale. And now we get kind of a sense of being able to apply to our own country the kind of things that happen in countries all around the world. So I've been given quite a bit of an open mandate for today. I really want to try and finish by, I think it's going to be 8 o'clock or a bit past then, so we have time for questions. But I'll just give a bit of a background on my area of specialization, which is community engagement in the context of disease response. Kind of go global from local in another place. So talk about the experience of the Ebola outbreak in West Africa, which I'm most familiar with. I still work on the Ebola outbreak in DRC, and really sadly today, we had another outbreak in DRC in another part of the country. So that's ongoing despite everything that's happening with COVID. And then I'll just compare that to the current response in COVID and kind of what the lessons that came out of West Africa and how they impacted how we're responding as a globe right now. And there is a clear link there, actually. So before I really start, I'm not very good at Zoom because I usually work for Bill Gates and we use Microsoft all the time. So there's a Q&A button down there. So please feel free to leave questions, and I'll leave 15 minutes at the end to run through those. And I'd really appreciate any questions or clarifications. So as Nick said, my main role now is a consultant to the Bill Gates Foundation. I actually shared an elevator with him for the first time the other day, but that's about as close as I've ever got. I've been doing that for about 5 years, and mainly just working on community engagement and disease response and how we can improve the quality of community engagement and disease response, how we can make it more harmonized, and how we can measure it and do better next time. We've probably got all our opinions on how well the government has or hasn't engaged with us over the course of COVID. Again, comparing experience in Australia and the US is probably very different. But there's a lot of work being put into disease after disease trying to improve this. So, the two things I've been working on are measuring it using data from Sierra Leone, and also, as Nick said, developing these minimum standards for community engagement, which are an international global good that's been developed to try and guide governments and implementing organizations to better do this. And now we're getting a chance to kind of test these standards in every country in the world, which is kind of unimaginable when they were first developed. But all of this is in the context of like a broader push across academia and NGO sector and government and funding agencies to improve community engagement post-Ebola. I'm not directly working on COVID now. That's happening upstairs. My wife Danielle is actually leading the community engagement COVID response for the Gates Foundation. So I vicariously hear about what's happening on that front. I still work with Unicef to try and look at the standard kind of architecture that it all fits into that crosses across all diseases. So before I go on, I'll just quickly talk about what is community engagement. Everyone will have their own understanding of what that means, but how we're talking about it in this context is an approach, and it's an approach that brings all elements of community, be it individuals or households or communities, business sector, governments, to kind of support collective action against threats. So this might be compared to something called risk communication, which we're more used to, which is where you get messages about what we should and shouldn't do. In Australia, we've got a particularly strong history of risk communication, be it HIV/AIDS messaging in the 80s, or seatbelts, or drink driving, smoking. Australia's actually got quite a good reputation. And one reason for that is it's always based on broad community engagement. What works with communities or for communities, giving that feedback to decision makers so that the services that come back reflect the communities. And it's very different across different contexts, Australia and Sub-Saharan Africa and Asia and South America. But there's a fundamental part of community engagement that we need to focus on, and it's participation of all elements of society, be it the vulnerable, disenfranchised, those who usually don't have access to power, and making sure that they're participating in planning. And when we think about community ourselves, we can each place ourselves in a variety of communities. It's not a monolith. We're all part of Ballarat, or part of Seattle, part of Australia, but we're also part of sporting clubs, the business community. You know, we're volunteers, we're parents, we're school communities. So all of these communities can impact us in different ways. And so trying to address community to change behavior, it can be quite sophisticated and difficult. So I'll just give a quick background to how I got into this, and then a kind of a quick overview of Sierra Leone, and then the broader kind of implications. So I've been working on microfinance for a lot of years, including for an organization based in Brisbane. And around 2010, my wife and I moved to Africa, first consulting based in Kenya, and then I ended up working for an organization called Restless Development. It's a UK NGO, a fantastic organization. I'm still on the board of Restless, so it's my job to encourage everyone to donate to that organization right now, and maybe I'll remind people at the end, but it's a fantastic organization, a youth organization that's truly led by young people, and their main role is to undertake community engagement, mainly focused on sexual and reproductive health, youth livelihoods, and civic participation. So it's really unique that it tries to engage young people to engage with decision makers. So they invented an approach, or developed an approach, that kind of uses peer education. Young people go and train to live in communities for 3 months, and they help those communities to access services, to better understand the services that are available to them, and act as kind of what we call community navigators between schools and health clinics, to create dialogue between all the different stakeholders in the hope of achieving better health outcomes, better civic participation and livelihoods. So the main role in this kind of network is to make lines of communication between two-way communication rather than one-way communication. I'm just going to open up and just put a few slides up and describe what this kind of program would look like. Hopefully you're seeing a screen right now. Let me double check that you're seeing that. So what we see here is a pair of volunteers going to work into community to act as community engagement officers. And these two young people would create some kind of infrastructure that would enable them to be able to do this over a 3-month period. So they would do things like teach in schools, teaching sexual reproductive health and civic participation, make direct linkages with healthcare centres, bringing nurses into schools and taking young people to the schools. Have a youth information centre where young people could drop in and learn about civil society and how they could participate. Livelihoods groups, so in this case is groundnut growing. They actually go into communities to do outreach and community engagement, and some fantastic drama that they would do. The high point of the team when I was there was having Angelina Jolie come and watch them do one of their drama presentations and give them very high marks for their acting. So it's a great way to engage with community in that context. And great acting goes on at the same time. Here they're doing a skit about unprotected sex and getting right into the responsibilities of men in that situation. Real focus on women and gender has to be a central aspect of community engagement, and then actually encouraging young people to do their own research and then share that with decision makers. So why I'm kind of concentrating on this is just to give a sense of the kind of thing community engagement. It's multi-level, and it's about creating those linkages with decision makers. So if we go forward to 2014 in Sierra Leone, this was a project of about 120 volunteers working in 60 communities. May 2014 in Sierra Leone, we had our first case of Ebola. And there'd never been a case of Ebola in West Africa before. And so this caused a lot of consternation. A lot of organizations, government down, didn't know how to deal with this, didn't know how to engage with communities. And there's a bit of panic set in, which we saw with COVID, in terms of how people respond to it and how governments respond to it in the early stages, which is very normal in a disease response, that people don't get it right at the very beginning. So we had 14,000 cases and just under 4,000 people died in Sierra Leone. You know, the numbers are nothing compared to the kind of thing we're seeing for COVID, but in a small country, for a novel disease, it was a big issue for that country, and especially one where you have an informal economy and a lot of people struggling and on the edge of you know, being able to exist anyway. So this outbreak, the West African outbreak, became kind of a catalyst for how we rethink community engagement in the whole sector of international development and humanitarian outbreak. And the reason is because even though the outbreak got to the size it did, small compared to COVID, but terrible in the sense of an Ebola outbreak, is that it should have been nowhere near as bad as it was. Many thousands of people died that shouldn't have died. You know, as we're seeing under COVID now, if there's not a good community engagement response early on, that encourages people to seek treatment and adopt the right behaviours, then things will get out of control. And so it was a real wake-up call for everyone who worked in the sector. And so we developed something for that outbreak called community-led Ebola action. And what that took is this smaller kind of program that I described earlier, and took that to a large scale. And we ended up working in 12,000 communities, which is about 80% of every community in Sierra Leone. So a country of about 6 million people. We trained 2,500 mobilizers in a month, and a network of 2,000 mosques and churches. It's about a 60-40 country in terms of Islam and Christianity. And why we work through those mechanisms at such a large scale is because key to addressing Ebola was working through leadership and identifying who the leaders were, and then working with that leadership, not trying to create new leadership, and especially not trying to come in as expatriates and tell people what they should and shouldn't be doing. So when it comes to leadership in that kind of response, one thing we learned is not making presumptions about who leaders are. The leaders in communities are not always the elected representatives. In this context, it could be the youth leader or the women's leader, certainly religious leaders. There's a whole lot of power related to community engagement and leadership. And we know that sometimes the kind of leaders we have aren't always the leaders that are looking after all of those different segments of our own communities. It's not possible for them to do that. And so we need to find who are the influencers in certain different communities. And so to do that, we need data. We need to understand who people listen to, why they listen to them, and then work through those people. And as I said, in the case of Sierra Leone, working with religious leaders of both faiths was essential. And we also recognised that polio had been wiped out through working through these religious leader networks, so building on that previous information. Young people especially, we found, were most influenced by youth entrepreneurs and successful business people. So the business community was important because they saw that kind of success as inherently trustworthy within the Sierra Leonean context. So we worked a lot with business. And then survivors of any disease are always good spokespeople for why you don't want to catch that disease. So I'm just going to quickly, again, run through like a last few set of slides on that response. And then talk about like some of the lessons and how we ended up. Sorry. All right. So hopefully everyone's seeing this. I'm going to go back to the start. Okay, where are we? Excuse me for a second. Okay. Okay, hopefully everyone's seeing that. So this is the team of young people that led the community engagement in Sierra Leone. This photo was actually taken the day before I flew to Ballarat many years ago, and so it was effectively a wave to Ballarat. So I thought it'd be a good photo to put up now. So essentially, what happened in this context is community engagement. You know, as Nick was alluding to, there's a range of measures in disease response that that are either very heavy or not heavy enough, and are difficult as a community to deal with and to take on board. In Sierra Leone, we had high levels of quarantine and stopping moving between districts. Actually, when I tell people that Australia is closing their borders internally at state level, people are aghast here because it's unthinkable within the US context, but it's really important that we stop people moving around, and I'll talk to that a little bit. But in Sierra Leone, where people really struggled economically, especially as an agricultural community, trying to move agricultural goods around, it was a real problem. The other issue was we're seeing PPE in communities, and during COVID, we talk a lot about the lack of PPE or the importance of PPE, and also how impersonal PPE is in a disease response. And so encouraging communities to get treatment when this kind of scary person is coming into your community, if you're having a case, taking your things out and burning them, and also PPE was worn for burials. And so in Sierra Leone, and this is a little bit of a contrast to what's happening with COVID, every single burial had to be undertaken by someone wearing PPE, a safe and dignified burial team. And then each person who died, whether it was a car crash or a drowning, they were tested for Ebola and buried by a burial team. That's how they got on top of Ebola. Now, that's not acceptable to a large degree in our society, in Australian society or in the US, and we don't have the capacity for that. One reason is governments probably don't feel that they can convince our communities, even though we've had some restrictions on burials and we are hearing terrible stories. Doing that for every single case or every single death in Australia would not be acceptable. And so there's limits to community engagement. And in Sierra Leone, it was deemed absolutely necessary because actually dead bodies were the most infectious source of Ebola. And so, it was a real challenge to try and do that level of engagement. Quarantine was quite strict and punitive, and you had police guarding individual houses to stop people from coming out. That was also a real challenge, trying to link up these people with food and with basic things they need for their livelihoods. So the response to that, like I said, was to train 2,500 people. The essential to community engagement is having trusted sources, people who communities know and trust and understand, who speak the same language, who look like them. You'll notice that I would go to communities to visit, but certainly wouldn't go and do community engagement because it wasn't my community and it wasn't my role. So these young people were trained not only to go and give messages about Ebola, but they were trained in two-way communication. They were trained in communication skills. They were trained how to talk to leadership. They were told how to talk to different kinds of communities. And they were also taught how to collect data on every visit that they did, which is very unusual for community engagement. But that resulted in us having a historical data set of the outbreak that is considerable, and I'll talk about later. So they would go and do these kind of community meetings where communities would be supported to design their response. That might mean we're going to stop people coming into our communities, or we're going to refer people as soon as there's a sign or a symptom. And this would give the ownership of the response into the hands of communities, and a chance for people to really express frustrations. And that lady's frustration in that photo kind of reflects some of the frustrations we see with COVID. People would use participatory methods to try and develop these action plans, following up with people if there'd been a case, actually manning alerts desks, so there was somewhere for people to call in if there was a death or if there was an illness in their community, actually taking messages from communities directly to leadership in this kind of meeting where decisions are made day to day. And this photo for me is the crux of the community engagement, where you have community representatives coming in and talking to those people who are actually making the decisions about the community. Negotiating between military and community, and then on top of that, the risk communication I was talking about. So that's reinforcing it at a national level. And Al Hassan was a real guy with an amazing story. And so telling those kind of positive stories and not just the negative, you will get this and it will affect you in this negative way, trying to tell positive stories. And then lastly, I always finish with this picture of Florence Bambali. She was a survivor. And it was amazing to see young people especially be so able to survive the disease, and it reminds me of COVID now, that we're seeing that young people are some of the more resilient when it comes to the disease outbreaks. So sorry if I kind of rushed through that, but I want to leave plenty of time. But it just gives it a sense of, at a local level, over a 2-year period, what communities are able to do and sustain if there's proper engagement. And it changed important aspects of the response. An example might be where the burial teams were being disrespectful. They were using the wrong color body bags. Male burial teams were coming in to get female bodies. All of these things changed and were able to improve over the course of the response. And so that's just a snapshot of what had to happen at scale in a hurry, but it happened very late. And ever since then, there's been considerable focus on how can we do that concerted, meaningful community engagement in all cases. And much of that centered around the role of Unicef and WHO. And just to touch on those, and then I'll start to head out to kind of the global view, that WHO, despite the bad press right now, is an essential, absolutely essential organization in disease response, especially in developing countries. Yes, they make a lot of mistakes, and they're a big UN agency, and so that's what happens. But WHO is in charge of the biomedical aspects. So they set up the burial teams and the surveillance teams, the contact tracing, which we're hearing a lot about now. They set up all of that. And then on the other side, Unicef is the organization that actually runs community engagement in disease responses in all developing countries. So even though they're kind of the child agency, that's one of their main roles. And then you have the Bill and Melinda Gates Foundation. Organizations like that are trying to fund better community engagement, better measure and understand it. It's not like a science where you can say this many people got sick, this many people didn't get sick, this many people recovered, this many people didn't. With community engagement, it's an art and a science, and it's quite intangible. What we're trying to do with the Gates Foundation is make it measurable and scientific, which we think we're starting to achieve. So from there, I'm just going to now spend five minutes just running over, like, so what does this mean? What is all this work that so the teams I've been working with, but also the broader community or community engagement community, what does it mean? And we've kind of boiled this down to a few things recently, and we've actually got some stuff being published in a couple of weeks on this, so I can share that if people are interested. But on the data front, and then back to kind of Nick's point about being frustrated with the kind of restrictions we've had on this, the work we've done over the last few years with the largest epidemiological data set from community engagement in Sierra Leone tells us that limiting movement between communities absolutely stops disease transmission. So there's some theories that it will go, it dies out at kind of a broader national level, or that it kind of has super spreader events and moves around. But what we find is if you can stop it at the household and then stop travel between communities, the disease will die out a lot quicker. And that's been the response of an Australian and New Zealand. It's not working in a lot of countries, but the countries where it is working, hand in hand with face masks and social distancing, that's why we've had success. So it's 100% evidence-based. And the longer we can do that, the shorter the pain over the kind of the longer term. There's a really strong correlation between communities being consistently engaged, not just one-off, instructions or messaging, but that there's time to actually, be more sophisticated with the messaging and how that communication comes back and forth. You can't communicate two ways if it's only one interaction. So interactions over a period of time in the data tells us that that's where you have most success with reducing transmission. And then the last one of kind of the data side of things is there's a strong link between addressing the unmet needs of communities and disease safe behavior. And I'm sure there's a lot of talk about that in Australia, as there is here, that we know the behaviors we need to do is social distance and wear masks and wash hands and stay inside as much as we can. But if you have unmet needs such as childcare or money or other medical issues or any range of things, depending on your community and where you're sitting, unless those other needs are met, then we can't do the disease safe behavior that we need. And that seems, again, like common sense to a degree, but there's not really much evidence or data out there for that. And we've just published something in the Lancet in the last couple of weeks that demonstrates that in the data. So that's kind of like, hopefully that gives some people a sense that it's worthwhile what we're doing. And you'll see over time, as we start to see second waves in the US and we start to see this go out over another year, I think everyone will be glad that they stuck it out for as long as they did in Australia and New Zealand. So now I'm just going to jump into, like, I'll spend a couple of minutes going over kind of like the key lessons that we've drawn from all of this work, and then, you know, pose a couple of questions for, you know, Ballaratians, the business community, and just hopefully this triggers some thinking as we start to open up, as we start to go back to businesses, but we could see things go backwards again, and there's going to be changes over a course of time. So I think I've already talked about defining community is important. It's difficult, but it's really important to know that we're not a monolith and that it's not a simple concept at all. It's important to remember that communities are active agents. So I think often communities are seen as passive in this kind of disease response. Certainly in a lot of other countries where there's issues of race and power, that does, you know, create some certain expectations about some communities. But what we want to ensure is that if communities are part of the loop, because if they're out of the loop, they're not participants, they're not consulted, it's going to undermine reducing transmission, and that's what we're seeing in the USA and other places, Brazil. So that's one reason to try and stick on top of this. Community engagement's got to be prioritized early on. And I would say this now is still relevant and important because we're going to go through different phases of COVID. And so it can't be an afterthought. We can't say, okay, we're coming out of a disease response now, so we can just, you know, pay less attention to how we're engaging with communities because we're on the other side of this. If it comes back again, people will regret, government will regret, you know, those in power will regret not continuing that engagement. It's a long-term thing. It's got to be happening in preparedness, during and after. So just ensuring that it's always part of it. We can create demand for services all the time, healthcare, but we've got to ensure that those services are meeting the demands of people. And I think same in business, you know, as we start to open up, we've got to make sure that community engagement is core because people are going to have a lot of questions about opening and closing, and how we manage that is it's going to reflect on you know, the individuals and the organizations that maintain that communication. The role of frontline workers, it's been so heartening to see, has to be prioritized. This again seems common sense, but in the development and humanitarian context, often the big NGOs and organizations come in, they expect community members to work as volunteers because it's their community, or they don't get paid much, or there's too many organizations trying to get the time of a whole range of different people in communities. But it's not just about praise for those that work in the response. It's really about paying them well and training them well and providing supportive supervision. So this is a real issue in development around those mobilizers that go into communities that I described, community health workers. But what we're seeing in COVID, that's all the essential workers that we never really understood as essential workers. People working in grocery stores, those that are delivering food, those that are doing social work, those that are maintaining all kinds of businesses within this context. They're not a means to an end. Now we know they're an end themselves. They have a role to model good behavior, to interact with communities. So anyone in business in Ballarat that's interacting with community now, that's a chance for leadership and engagement, making sure that staff are trained, that they can answer questions. We all have a responsibility here. So even if it's not directly related to our business, you know, imagine a pizza delivery driver that is modeling the right behavior, doing everything right with hand sanitizer and a face mask, but also trained to clearly explain what's safe and what isn't in the context of food delivery. You know, just making sure that everyone is able to give that right information to people. People are isolated, and contacts with business community is some of the only contacts they're having. So it's kind of the onus is on us to make sure that everyone is trained. And that kind of comes to the next part about coordination. community engagement is terribly coordinated in disease response in developing countries, because it's a sense that everyone can do their own thing. You know, you'd never send a bunch of doctors in to do their own thing, but it's very common for organizations to send community engagement officers just to go and do their own thing. So we want everyone pulling in the same direction when it comes to community engagement. You know, same messaging, same approaches, same data collection, so we can understand what's happening. So, you know, that happens, it's important at the local level too. You know, a government and business and service sectors all on the same page and kind of mutually reinforcing each other, especially as we start to open up. Our businesses working together across, you know, to have consistency across approaches. It only takes a few chinks in the armor. You know, bad practices from one organization can lower standards for everyone. And so trying to maintain consistency across organizations, and also so customers, community doesn't have to second guess when they go into a business. They know exactly what they're getting and that they're going to be safe. And also engaging, and this is less relevant here, but making sure that community engagement is integrated with, we call the biomedical response, so that you know, community engagement is just not giving messages and expecting people to behave, but also anyone who's doing health work is able to also reinforce the community engagement messages. And then just what's business doing to support frontline workers and other, you know, social service workers. I see there's been some like, you know, like supermarkets opening on specific times for frontline workers. That kind of thing is amazing, and anything we can do to support frontline workers and integrate the health system into what we do is really important. And then I'm just going to finish up with the last thing that's really important, and that is real-time community data collection. Understanding it's an essential input to guide decision-making around community engagement. You know, what are people thinking? How are they thinking it? And what sectors of society need specific kind of engagement and needs? Too often this is kind of placed in a common sense basket, but it's not so easy. We really need to focus on like particular segments of communities and make sure that we're collecting data on what moves them and what doesn't move them. Because the easy part is communicating, washing hands and self-isolation and wearing masks, but the how of that implementation is the hardest. And we need to understand from communities, what are they having the most trouble with? The what if question. You know, I experienced it the other day with my daughter who has asthma. You know, she got sick, and then it's like, well, can I go to the hospital? Do I need to go into quarantine after that? Is there a risk of going to the surgery? Should I go to the emergency room? So, you know, I knew that she had signs and symptoms and I had to do something. That's the message. But it's all the how of implementation that's tricky. And I can imagine as businesses start to open up, the what ifs are going to be legion. And we might say, well, the government's giving guidance, but how does that impact this sector and this sector and this kind of business? And this is going to be really difficult. And there's going to be questions from customers and service providers all the time. And that's where the rubber hits the road with community engagement. I just get the sense that all sectors are going to be assessed in terms of how they engage with communities over this changing period as we go back and forth, as we see more cases. Who knows what gets thrown up again as we learn about the disease. You know, reinfection, you know, the after effects of it, we don't know how that's going to affect people. So if communities, businesses have a plan on how to continue to work together and engage communities, I think that's going to be essential. And so that all those kind of lessons are coming out soon in a publication that we're putting out. I'm happy to share all of that with anyone that's there. I'm going to kind of wrap up now, and I see there's some questions coming through. And so I'm going to just ask the questions and then answer them. I'm sorry I can't hear people's voices for that. Peter Flynn asks, if the organisation hadn't done this work, what would the estimate of deaths have been? It's a fantastic question, because the modelling is getting more attention than we've ever seen before. I work with a team of modelers here. One of my very close friends down the road here is one of the lead modelers guiding the Washington response here. And modeling is really tricky. So Peter's question is really hitting the nail on the head, that when we do modeling, you know, how many deaths are expected or how many cases will be expected. There's different kinds of modeling. There's modeling that doesn't that says if we don't do anything, this is how many cases. So in West Africa, they said 1.5 million cases if there was no intervention, which seems crazy and doesn't seem accurate, but that's kind of numbers that were being pushed out there. The main answer right now is we don't know, but that's what we're working to try and do. So we're trying to take the engagement aspect that we did and then compare that to the original models, and then try and estimate some kind of lives saved. So that's coming. We don't know. I mean, in the COVID context, we're definitely seeing, predictions of, there was 30 to 40,000 more deaths in the States than there needed to be, and often it's just a timing issue. So that is a whole other field of expertise that's a big debate at the moment about how do we fit behavior change and community engagement into modeling. And so, yeah, the answer is we don't know, but that's what we're trying to prove at the moment. John Stewart asked, after the initial pandemic was over in West Africa, was microfinance key to getting the economy going again? That's an interesting one. I can really only speak to Sierra Leone. For those that don't know microfinance, and I think we should, most people are aware by now, but microfinance is the idea of trying to bank the unbanked. So getting loans and saving mechanisms up and running for people who don't have access to the traditional banking sector. Unfortunately, West Africa is very tricky for microfinance, just for from cultural reasons and some reasons associated to lack of support from a lot of the governments. What happened in Sierra Leone is when Ebola came, unfortunately, 2 or 3 of the main microfinance institutions left overnight. That meant no one needed to repay their loans. What happens when people don't have to repay their loans? Well, it's very hard to run a financial sector if people are thinking that they can get their loans relieved. And so actually microfinance is up and running again, but I wouldn't say that it's been key to getting the economy going again. Depending on the country, I know in Sierra Leone, it's definitely the resources sector, it's the iron ore sector that kind of got things going again. But that is not to say that microfinance isn't absolutely essential in all of these contexts. Yeah, I think that the market was kind of distorted a little bit post-Ebola in Sierra Leone, unfortunately. Marianne asks the notion of fake news and increasing mistrust of traditionally trusted sources of information, including WHO, seems to be more and more prevalent. Do you have strategies to reassure communities and counteract the way the fake news can be used to generate fear and mistrust? Based on what I was just saying, the main strategy for a community, any community member should be find what your trusted source is and listen to that person. We're seeing false information for the COVID outbreak like we've never seen before. There was a lot during Ebola, but because social media wasn't as widespread, we didn't see so much. It didn't have such an impact. But I think the main strategies are just stick to trusted sources and sharing those sources with those that you can. We're never going to be able to get rid of kind of how pervasive it is online. I think there's a real challenge for government to think about how they might regulate this kind of thing. And as you can see, there's a debate right now with Twitter and Facebook about how that kind of fake news might be better regulated. I think that's going to be the solution longer term. And I think if we have a change of government here, that might happen. I think it's getting to the point now where it's starting to cause loss of life, especially Facebook. We see in areas like Southeast Asia and South Asia, there's been quite a few deaths because of people following fake news on Facebook. So yeah, the solution is to try and trust sources and listen to them. Like WHO is a good source. If someone is trying to undermine the validity of someone like a WHO, then I think it's worth doing your investigation about why they're trying to undermine those institutions. And then Whitney says, thank you. So I think we're right on time. And I'd be happy to share my contact details via Jody or the team if anyone wants to get in touch with me. And I'll wrap up there and hand back to Nick. Thank you.
Thank you, Jamie. That's been a terribly interesting morning. So terribly is the wrong word to use, but it's been a very really interesting morning, and I'll be the first to say I probably wasn't quite expecting the level of detail and context around the work that you've been doing. So, Jamie,
yeah, sorry for too much, everyone.
But just so incredibly relevant to what's happening in the world right now, and you know, we're very fortunate to have someone with your experience and expertise talking through some of the challenges those countries have had. So, on behalf of Commerce Ballarat, our viewers today and also our sponsors, thank you very much for joining us all the way from Seattle this morning. So have a great afternoon.
Great.
And I hope everyone in Ballarat and in Australia has a great morning as well.
Thanks, everyone. Have a great day. Thank you.
Thanks, guys.